All right, good afternoon. Good afternoon, everyone. Thank you for joining us for today's medication-assisted treatment echo clinic. We'll start off with introductions. So we'll start off with the hub team for today, and myself as the facilitator, Troy Jorgensen, program manager for Project Echo Nevada. Shalene, go ahead.
I'm Shalene. I'm a pharmacist at Hopes in Northern Nevada.
I'm Dr. Joe Ryan. I'm an emergency medicine and EMS physician in Reno.
I'm Echo Troop. I'm a licensed clinical social worker with the MAP program at Northern Nevada Hopes. Good afternoon. My name is Danica Pierce. I'm a licensed clinical social worker, and I'm the MAP program coordinator at Northern Nevada Hopes here in Reno.
All right, and we'll go out to our remote sites joining us today, our remote hub teams. And Al, you want to go ahead?
Sure. My name's Al Hassan. In fact, I think, Danica, you were at a training that I did on MI in Reno probably about 2 years ago. I think I recognize you folks. Yeah, you guys are.
Yeah.
Yeah.
Hello again.
Hello. Yeah, my name's Al Hassan. I work here at the UCLA Integrated Substance Abuse Programs and with the Pacific Southwest Addiction Technology Transfer Center.
Thanks, Al. And Ben, go ahead.
Yeah, sure. Hi, everyone. My name is Ben. I'm also with the Pacific Southwest Addiction Technology Transfer Center, and then one of their newest grants, which is kind of supporting this presentation today, the Opioid Response Network, STR-TA.
Welcome.
Thanks, Ben. And then Jennifer, we'll go to you next.
Good afternoon. This is Jennifer Trujillo. I'm the Substance Use Disorder and Special Populations Program Manager at Nevada Primary Care Association.
Thanks, Jennifer. So then we'll go out to our spoke sites joining us today. So for those of you who are new to the format, we like you to share your name, your credential, and your place of work. So Denzel Hockenberry, you want to start us off?
Yeah, I'm Dr. Denzel Hockenberry. I'm the Director of Addictions and Recovery at Community Care of West Virginia, in West Virginia.
Welcome.
Wonderful. Glad you're joining us today. Thank you so much. Dr. Andraki, go ahead.
Oh, good afternoon. Stephen Andraki. I'm a primary care physician and also addictionologist. I'm in Pahrump, Nye County, Nevada, and it's good to see more participants. I've been doing this for a couple of years.
Thanks, Dr. Andraki. Rick Obringer, go ahead.
Good afternoon, everyone. Rick Obringer, physician assistant, orthopedic surgery, Las Vegas.
Thanks, Rick. Tanya Skidmore, go ahead.
Hello, my name is Tanya Skidmore. I am a physician assistant, and I work in family medicine and also in education at Lincoln Memorial University in Tennessee.
Wonderful. Glad to have you today. Thank you. Christine Siperin, please go ahead. Oh, just a second, Christine. I'll take you out.
Sorry. Can you hear me?
Yep.
Okay. My name's Christine. I'm a registered nurse on an inpatient surgical unit, and I am in a master's program where I'm learning how we can influence vulnerable populations.
Thanks, Christine. Good to have you today. Next is Erin Ramsdell. Please go ahead.
Hello, my name is Erin. I'm a registered nurse down in Carson City, and I'm also at UNR as a student in aggregate populations class.
Thank you. Good to have you. Dr. Kamyar, please go ahead. Just a second. There you go.
Hey, Farzad Kamyar here, psychiatrist and MAP provider for OUD at the Mother Program High Risk Pregnancy Center in Nevada.
Thanks, Dr. Kamyar. Next is Skylar.
Hi, my name is Skylar. I'm a nurse practitioner in Jackpot, Nevada. I work for Nevada Health Centers.
Wonderful. Good to have you today. Thanks for joining us. Next is Sam Rutherford. Please go ahead.
Hi, good morning, guys, or good afternoon. My name is Sam Rutherford. I'm a telemetry nurse at Renown and a UNR student at the Aggregate Populations course.
Thanks, Sam. Good to have you. Lorraine Ramirez, please go ahead. I'll take you off mute. Go ahead now.
Hello?
Yep.
Hi, I'm Lorraine Ramirez, coordinator with the Arizona Rural Women's Health Network.
Thank you. And I think your colleague Leah is joining us as well. Leah, please go ahead.
Hello, Leah Myers. I'm a social worker and the director of the Arizona Rural Women's Health Network.
Thanks, Leah. Good to have you back today. Next is Dr. Michael Koss.
Radiation oncologist, Reno, Nevada. I work in a radiation oncology clinic.
Thanks,
Good
Dr.
morning.
Koss. Next is Dan David in our group at Northern Inyo Hospital. Dan, go ahead. Do we have audio for you today?
Hi there.
Yep.
Are you guys there? Hi. It's Linda, Arlene, Dan, and Hallie all joining you from Bishop, California, where we have an MAT program at a rural health clinic.
Welcome back, guys.
Hi. Thank you.
Thank you. And then the last is Jason. Jason, could you introduce yourself? I've taken you off mute. Jason, do we have a microphone for you? Okay, no problem. If you could just write in through the chat box and let us know who you are, where you're from, that sort of thing, that'd be great. So thanks so much, everybody, for walking through introductions with us. So great to have a lot of new faces joining us today, as well as some familiar ones. So first, what we do through ECHO is we want to support you with your challenging patients, your difficult patient cases, any questions that you might have doing MAT therapy or addiction treatment, anything like that. So please feel free to unmute yourself or write in through the chat box anything that you'd like to discuss today. All right, so we'll have some time for Q&A at the end and any other cases that you might think of, but we'll turn it over now to Ben to do our introduction for today's presentation. So Ben, take it away.
Yeah, I'm not sure if you wanted Jennifer to kind of do her brief about Nevada Primary Care Association first, and then I can take it from there.
Sounds great. Yeah, Jennifer, go ahead.
Yeah, just a little background. Nevada Primary Care Association is a nonprofit organization dedicated to improving access to high-quality, community-based, affordable primary health care in Nevada. We provide training and technical assistance to health centers and community partners to improve access to health care for all, especially for the underserved and uninsured population. To learn more about our training opportunities, please visit us at NVPCA. And this training is in partnership between us, Opioid Response Network, and Project ECHO. And I just wanted to take a moment to thank them for helping us coordinate this session.
Thanks so much, Jennifer.
Great, thanks, Jen. All right, so I can take it from here. I have the screen, is that right?
Just click on there and then it'll advance the slide for you. Yep.
All right, so just an overview for what the Opioid Response Network is. So the Opioid Response Network was created with SAMHSA State Targeted Response Technical Assistance Grant money that runs from 2018 to 2020. And basically, the initial intent was to assist mainly STR, State Targeted Response grantees with the state. So with Nevada, that is Stephanie Woodard and Michelle Berry and different people at CSAC at UNR. But also, the Opioid Response Network kind of in implementation broadened itself to assist all individuals, not just with the state, but people in the community and other organizations, such as like the Nevada Primary Care Association, and really to bridge a lot of the perspectives for prevention, treatment, and recovery and deliver those to community members. And so what we do is we basically provide resources and technical assistance as well as education and training to local kind of individuals and communities by either partnering with local organizations, providing local consultants, or bringing in others that have the expertise and experience with the requested topics. And one of those topics today is requests for ethics and kind of treatment and addiction and alcohol and other drugs. So technical assistance is available to support different kind of evidence-based prevention, treatment, and recovery for opioid use disorder, as well as substance use disorder. And so kind of just, again, an overview is we provide local experienced consultants or statewide or national ones in prevention, treatment, and recovery to be able to provide education and training to local communities and organizations. And we accept any types of requests for education and training. You can always do so on our website, which I'll get to. And how it's organized is each of these is organized across the nation through each health and human service region. So I am the technology transfer specialist that kind of operationalizes the work between the different consultants, taking expertise, experiences, and matching them with needs and turning things into actionable items and deliverables, such as training and education, as well as targeted kind of project support for different initiatives that the community would like to request. And so I'm with the Pacific Southwest Addiction Technology Transfer Center, and that is Health and Human Service Region 9, which is where Nevada falls within. And then just a disclaimer, funding for this initiative was made possible in part by this grant through SAMHSA. So the views expressed and written in conference materials or publications and by speakers and moderators don't necessarily reflect the official policies of the Department of Health and Human Services, nor does any mention of trade names, commercial practices, or organizations imply any endorsement by the U.S. government. So again, really this approach came through SAMHSA and Dr. Eleanor McCann-Cass as a way to build upon existing efforts, the different technology transfer centers, as well as the different state targeted response efforts to enhance and refine and fill in the gaps rather than recreating the wheel. And again, this is our overall mission, which I said before, but these are kind of standardized slides that give an overview of that. We provide information about prevention, treatment, especially medication-assisted treatment like buprenorphine, naltrexone, and methadone, as well as recovery and different innovative practices on that forefront. And so if you do have any questions or would like to submit a technical assistance request, which is free to you, so Jennifer did request kind of support around this, and so that's how we were able to be brought on. You can visit our website at opioidresponsenetwork.org, and you can also email orn@AAAP.org. That is the host agency, the awardee, and the PI of the grant, the American Academy of Addiction Psychiatry. And then you can also call the number for general inquiries as well. And other than that, I will let Albert Hassan take it away. This presentation was originally developed by our Integrated Substance Abuse Program's other psychologists there. And so thank you, everyone. Take it away, Al.
Excellent.
Thanks, Ben.
Thank you, Troy and Ben, and I want to thank you folks for allowing me to share, part of your day with you. I think that the two cases that were brought up certainly highlight some of the ethical challenges that we have, especially in dealing with individuals around MAT. I wish that when I was running treatment programs, MAT treatment programs, that I had sort of a forum like this where I could share with others, around cases, difficult cases and challenges that are experienced. Because certainly, the information, the knowledge, the experience that you all have in terms of that collective experience, I think really helps to guide what folks would be able to do in terms of their clinical care. So and with that, around sharing information with criminal justice system, with other community healthcare providers, as well as helping to inform an individual around what medications are available. And certainly as we see the emerging data, and Dr. Kamar, I really appreciate you providing us some information regarding both the oral naltrexone and the extended release naltrexone in the form of Vivitrol, because for years and years, that really wasn't the recommended treatment of care. And so hopefully there's that additional data out of Tennessee, and I'm certainly going to look that up to see sort of what the state of the art is now. And I think it's really incumbent upon all of us to stay informed as it relates to emerging trends and evidence-based practices. So thank you all. So with that, let's see, I guess I need to click on here and then advance the slide. So in terms of that, what do you, there's a range of expertise. There's a range of professionals that we have, in the room with us today. So what do you see as ethics and ethical considerations?
Any thoughts out there? Please feel free to unmute yourselves with the little microphone icon on the Zoom screen or write in through the chat box.
Okay, so Leah says confidentiality. Yeah, absolutely. And that touch based on what Dr. Andraki was saying is, the sense that, if I can bring in other resources in the community to help me make inroads with this client, I'd really like to, but we don't have those things in place. So yeah, absolutely. Confidentiality is one of those. Thanks for bringing that up.
I have one.
Go ahead.
How about continuing to prescribe MAT when it's really difficult to know if they are diverting their medication, and trying to split that line to keep them into practice, or to continue to give them chances and to figure out when you need to discharge a patient?
Yeah, is that Dr. Andraki?
Yep.
Yeah, so Dr. Andraki, certainly, knowing when the treatment that we're providing to individuals is working or it's not working is certainly a challenge. Having mechanisms in place to be able to monitor and to reduce any impact, any diversion if possible, and having protocols in place that allow us to guide the decision process when we run into issues like that. If somebody comes in and we know that they're supposed to be taking methadone, or we know that they're supposed to be taking buprenorphine on a daily basis, and they come in and there's a negative UA. Well, did they provide somebody else's UA? I mean, are they sort of tampering with the UA results, or in fact, are they not taking the medication? And that will require a pretty direct conversation with those individuals. So yeah, those are certainly ethical concerns that folks are challenged with all the time. And I would open this up to the other doctors in the room. So what do you do in the instance when somebody is mismanaging their medication? It's a little bit easier with methadone. You remove any take-home medications or take-home privileges that they have. How do you manage that when you're working with somebody who's currently on buprenorphine? And I'll open that up to the doctors.
Well, I think the fundamental ethical principle that guides practice in medicine is, above all, do no harm.
Mm-hmm.
And if you apply that principle to your actions, hopefully you would be able to discover a bright line of what you can do and not do.
Good. Thank you. Who is speaking?
That's Dr. Joe Ryan.
Dr. Ryan, thank you very much. I appreciate that. Anybody else?
We will frequently bring our patients in more often and put them under tighter control.
Yeah. So
coming in every few days and only prescribing a very small amount of medication at a time.
Mm-hmm. Okay, good. I like that. So for years I worked with the Department of Probation in Santa Maria, California, and one of the things that we did was actually induct individuals onto naltrexone while they were in custody, and they would get released to us. And one of the ways that we ensured medication compliance was we'd have them ingest one dose in front of us, and then we would give them multiple doses. This was pre extended release, and then we'd give them multiple doses to take home. Well, when somebody was somewhat reluctant to take a dose in front of you, you knew something else was going on, and so usually we would do a monitored drug test. And so, as you mentioned, I think I have you listed as Dan, but your voice doesn't match what I would. Your voice is a little high for what I would. Anyway, I won't go that direction. I'll get myself in trouble. But I think what you mentioned in terms of bringing people in more frequently when you are concerned about medication compliance, I think is a really good tack. Thank you. Good job.
I think Dr. Hockenberry, did you have a comment?
Well, that's one of the things that I was going to say, and also increase the case management and make sure that we stay in good contact with the patient.
Yeah. Yeah, absolutely. I mean, you know, it's generally we can pick up, and I think Dr. Hockenberry, your point's very well taken, is like we can recognize when something's going wrong with somebody, when something's going awry and it just doesn't feel right. And so instead of playing like cop, I gotcha, you know, let's try to provide more support for them and try to figure out what's going wrong. So thank you for that. So in terms of ethics, really they're a code of conduct, and you know, and as Dr. Ryan says, really our goal is to do no harm. We have an obligation to our patients. We have obligation to the standards that are set forth in the profession that we work in. And generally they come from shared morals and values and judgment about, you know, doing right or wrong. They're created in society. They're created, you know, by special groups or organizations. And the purpose of these things really is to preserve the integrity of the group that we're working with or we're working under. Promote professionalism and quality of service, and we don't see this just within healthcare, but this is throughout the provision of service organizations. But it's more so important in healthcare because an individual's life or well-being is at stake. So when we look at ethical guidelines and standards, we want to take a look at the role that we play with our patient. The philosophy of care that both we have plus the organization and maybe the broader organization, you know, whether it's the American Society of Addiction Medicine or whether it's medicine or the Board of Behavioral Science examiners as it relates to LCSWs or LMFTs or for that matter, you know, as well certified addiction counselors. But we have to take a look at those standards, those guidelines within each of those organizations and within the organization that we actually work for. So it guides our actions at work. But, you know, what's interesting is we have codes of behaviors outside of work as well. I mean, there are certain things that moral values that we carry outside of work and not just within the organization that we represent. So this is just an example of what we see, and I'm not going to go through this list, certainly, I think, but this is an example of code of ethics as it might relate to certified substance use counselors. And we know that, you know, social workers, LMFTs, physicians, all have a code of ethics that really we look to adhere to. So in terms of specific ethical issues around substance use treatment, so, you know, there are certain issues that come up for us. And I'm wondering for you, you know, there were two examples that were mentioned here today, but what are some other ethical issues that have come up for you within the organizations or within the purview or the facilities that you're working in now? What are some challenges that you've had?
I know one for us, and I'm sure this is very common among lots of providers, but one thing that's always kind of a challenge is when you do an assessment of somebody, you're working with a client who, based on your assessment, needs a certain level of care that is not available. What do you do with that? Where, you know, for example, you know, you think they need an inpatient program, but they can't get access to that. And so then is it ethical to, you know, to continue to treat them on an outpatient, you know, on an outpatient level if that's really not what they need? If they need additional treatment, they need more structure. And, you know, is subclinical care really better than no care? I mean, those kinds of decisions that you have to make based on individual folks and what's available.
So is
Danica?
Danica?
Yeah.
Okay, yeah, great question. You know, it certainly in what we see in rural areas and certain within California is that they don't have the full spectrum of level of care as it might be described or outlined by ASAM. And so, you know, I think you hit it on the head as it relates to structure. So how can we provide a level of structure that we might normally find in a residential program on an outpatient basis? And I think you as providers probably end up having to do that all the time. Sometimes it works, you know, because we have people who are, you know, more amenable to taking, you know, that kind of direction. Sometimes it doesn't work. And so what we do know is that any care is better than no care at all. If we at least make available to the individual the care that we have within our community, at least we can make a determination as to whether or not it has a potential to work. But additionally, what we can do is, you know, within that structure, we can increase the frequency of which somebody comes in, the length of time that they stay in, involve more community resources to enhance our ability to make change with that individual. But certainly what you described is what we experience here in some of our more rural areas of California as well, is that we don't have all of those levels of care available. For that matter, even when we do have those levels of care available, for an individual who is incredibly resistant to following direction, incredibly resistant to care, they may actually have gone through the quota or the opportunity, they may have already utilized the number of opportunities that they have in residential care, and the only thing that might be available to them is intensive outpatient at that point in time. So yeah, those are incredible challenges. I'd like to hear from the group what has been successful in addressing, in looking at those sorts of challenges where the level of care that we would like to see somebody in isn't available within the community.
I know we've got rural participants joining us, so I know you've got something to say about that.
Well, I'll tell you a story about a patient that I had last week. The 17-year-old boy that comes in with a borderline personality, conduct disorder, opioid use disorder, and stimulant use disorder. During the evaluation, he admits that over the last 2 weeks, he's been suicidal and he has a plan. His parents just act irritated by it, but now he's told us that he's actively suicidal with a plan. His parents didn't have the ability to take him to the hospital because their vehicle wouldn't make it. So we called the ambulance. The ambulance couldn't go past the little hospital that didn't offer the services because of the hospital, the rules. So we ended up using as much ingenuity as we could come up with. I called an ER buddy of mine, sent him over to the ER. The ER sent him up to another hospital, which then transferred him to the proper level of care about 80 miles away. So I think just, you know, using all the ingenuity that you have is pretty important.
Wow, he's a lucky young man to have come across. Is that Dr. Ryan?
Dr. Hockenberry.
Dr. Hockenberry. I'm sorry. Thank you very much for sharing that. He and his family are pretty lucky to have come across an individual like yourself who are willing to work around the constraints that exist, because otherwise, if not, bad things are going to happen with this individual. And so I think what you described as being flexible trying to figure out, utilize all the resources that you have in the community to make it work. And I wish him well, and I commend you for doing what you did. Nice job. Anybody else? Okay. Well, we'll go ahead and move on a little bit. So ethical behavior requires really more than us just having taking a glance at what our code of ethics is and what the law presents. I mean, it really requires sort of us doing the right thing, for the right patient at the right time, and certainly at the right location. And, it requires an understanding of what our policies are. Yet, understanding policies and procedures is one thing. I doubt that that last case would have fit into any policies and procedures in any of the organizations that I've had the opportunity to work with. As you described, Dr. Hockenberry. And so, yeah, you're going to have to work within the constraints that you have and know those are the rules, the regulations, and the procedures. Ethical behavior includes, non-discriminatory behavior, avoiding bringing personal, professional issues into the workplace, being aware of, any stereotyping that we might have, and being knowledgeable of certain disabling conditions. It used to be that for years we looked at the treatment, our substance users really as individuals who were criminal, who were morally bankrupt, maybe who weren't very intelligent, and really it wasn't until Ellen Leshner, who was then the director of the National Institute on Drug Abuse, really went to Congress and forced the issue and told them to really look. There's evidence, there's data that exists that show that this is a brain disorder. We can't just lock everybody up. And so, it's that knowledge, and certainly the knowledge that Dr. Kamar shared, around evidence base, around the evidence behind extended release naltrexone, that really helps us to move beyond, sort of just making haphazard decisions. And that includes, again, our respect, our knowledge about institutional policies, our professional policies, taking that initiative to adjust those policies when necessary, and being able to work around those policies to the betterment of the individual and to the help to really the health of the individual. Looking at skills in acquiring additional knowledge as you're doing at this point in time, sharing, practices with individuals so that we can we're better suited and we have a greater knowledge and understanding of the disease in order to be able to address it. And then reporting unethical conduct. And certainly, we've seen individuals who are working in programs, and it cuts across all professions, whether it's criminal justice, whether it's law enforcement, whether it's healthcare. We're under a number, we're challenged, and sometimes the way we react to those challenges may not be the best way to do that. And so fortunately, there are professional services available to those individuals. In terms of being competent, ongoing education, knowing what those boundaries and limitations are, our competence, and working within the scope, our own scope of work. And then not offering, services that are beyond our scope of work as well. Legal and moral standards, being aware of federal and state guidelines, not claiming that we have an affiliation or possess the skill level to be able to provide services that we don't, and ensuring that products or services are provided through that really have an evidence base to them. Public statements, stating things of fact. What do they say? Multiple anecdotes don't equal data. I mean, yeah, I mean, there may be trends in some things that we're seeing within our organizations, but we can't state those necessarily as fact. Acknowledging and reporting substantiation and support for statements, really looking at what the evidence-based practices show. And Dr. Kamar, you said, look, there is some evidence. You didn't say unequivocally that there's evidence for the use of naltrexone or extended release naltrexone in pregnancy, but you qualified that, and I was impressed with that. So, and then publication credit. I don't know how many of you actually work on publications, but really ensuring that the author, anybody that contributes, do get recognition for their contribution, but rather also making sure that the author has made the principal contributions. Any acknowledgement, takes place either in an author line or a long footnotes or other additional acknowledgement as it relates to contributions. And then the client welfare, and as was mentioned earlier, really what we want to do is what is best for the client at the time. And it's going to be important for our patients, our clients, to know sort of what our responsibilities to them are and what we expect in terms of their responsibilities to the program. We talk about terminating relationships when they're not benefiting. And I don't necessarily mean just terminating a relationship, but coming up and finding other solutions, finding other interventions that might be more appropriate for the individual. If they need a higher level of care, and that higher level of care is available, ensuring that that person has access to that higher level of care. In terms of privacy and confidentiality, I mean, really, most organizations have in their orientation, they have documents that will address privacy, confidentiality, reporting requirements, and reviewing those with the clients and patients is important, and making sure that they have these things in writing as well is important, and that we're not just handing them the orientation manual, asking them to to sign off on it, and then putting their signature in the chart. That's you may not be doing that, but that was actually a common practice in a number of programs here in California. So in terms of, we providing them rights and confidentiality, I know most programs have an orientation manual that gets reviewed with the client, and adhering to HIPAA and CFR as it relates to laws around confidentiality. So I know we're going through this pretty quickly, and this really isn't meant to be an exhaustive sort of coverage of ethical behavior and ethics, but rather just to touch base so that in some ways a reminder, not necessarily a reminder, but just as a way to sort of refresh individuals' memories. When we look at interprofessional relationships, certainly what we want to do is refrain from professional services to a client in counseling who is also receiving professional services from somebody else in counseling, in clinical service. Though what we do know is through case management, that does occur, and we want that to occur. We want physicians to know that somebody is receiving maybe counseling with a psychologist or with a psychiatrist, at the same time concurrently. We also want, the OBGYN to know that an individual is receiving services, substance use services. So in many ways, what we have to do is to ensure that case management services are being provided, but that releases are in place to allow that to occur. Yes, there's going to be some overlap, but generally that's to the benefit of the client. And then ethics committees, responding when there's some questions or concerns about about behavior of an individual who's working within the field. And then obviously, not exploiting relationships with supervisees or employees or students. And we talk about this, and in some ways we look at this and we say, well, it's obvious we're not supposed to do that. But for some people, it's not so obvious. And so for you, those of you who are in supervisory positions, yeah, you have to remind folks of our ethical behavior as it relates to relationships, both with interns and employees who may be subordinate necessarily to us. And then in terms of payment, inform the client of the financial policies. And, this has always been a challenge within the field of substance use treatment, and especially in MAT, when somebody doesn't pay their MAT services, do you turn it over to a collection agency? How does that work? I mean, in many of the organizations that I've worked with, they just ended up, keeping really close contact on what somebody's bill were, trying to make sure that they were paying timely in that, and trying to come up with other resources that they might be able to access in terms of public or third-party payers. But ultimately, sometimes individuals needed, they got discharged from the program, and that meant that they weren't going to receive MAT services. Fortunately, certainly here in California, there's more and more there's a greater number of individuals who are eligible for MAT services without having to pay on their own. I'm wondering, from your perspective, how you handle sort of financial challenges that clients have in your MAT programs.
One thing that I've learned is that if people are on buprenorphine, they can buy buprenorphine tablets a lot cheaper. They're $1 or $2 a piece versus strips or even the generic strips. So that's one thing. The manufacturer used to give 3 patients who did not have insurance opportunity to get free Suboxone for a year. And the rest of my patients fortunately have Medicaid, so it works out pretty well for them.
So it works out well for them. Yeah, good stuff. Okay. Anybody else? Yeah, I think with the opioid epidemic, services are made much more widely accessible than what it used to be. And certainly that's here, the case in California. From what I've heard, it's similar in Nevada and Arizona as well. So in terms of our societal obligations, I mean, really, we're all busy, and it's really a challenge for us to engage in developing public policy, changing public policy, unless that is really what we're paid to do. Though on a smaller scale, we do have the ability to make changes to policy within our organizations. Certainly at a county level, we see that all the time, where county administrators look to program personnel to help develop policy, to help change, to help amend policies that are currently being in place. So in terms of our client relationships, when we think about the relationships that we have, with our clients, our clients might want to have a social relationship. We actually may live in an area, sometimes if we're in a rural area or a very small community, where we run into our patients, our clients on a fairly regular basis. When I was coaching youth basketball in Santa Maria, it was not unusual for one of my patients to have a son or a daughter playing on my basketball team, or run into somebody in the mall and they'd come up and start talking to me and say hi. And my friends would say, "Hey, Al, how do you know that guy? Where do you know him from?" And so, those types of challenges, especially in the smaller communities, take place. Business or bartering, gift giving, counseling to family or friends, romantic or sexual relationships, dual or multiple relationships. These all create challenges for us as professionals, and also us as individuals within our organization. I had a client that came up to me, he couldn't make his payments. And so he said, "Look, Al, I'll give you my watch." You can't do something like that. It's just, while, on the surface, it might look like you're helping the individual out, ultimately you end up blurring the relationships that you have with the individual, and ultimately end up sort of compromising that relationship and the care that you're providing to that individual. So, an example is, you might give something to somebody, one of your clients, and they come back and they make up a music tape for you, and they say, "Hey, look, I know you like this music. I'm going to give you a tape." And, the next thing you know, before too long, the relationship begins to escalate. It's kind of a strange picture, I know. But their idea of what the relationship is moved beyond really what you think the relationship should be, or what you would like the relationship to be. And so what ends up happening, and it's not just with sexual relationships, but it's with relationships that take place outside of the milieu, of the clinical milieu. Sometimes we might lose some objectivity in terms of, it may have negative impact on the individual's mental health. They may lose some trust. If the relationship goes awry, they may lose trust altogether in the helping professions and tend to not seek additional care outside of your care. And so, again, at the very least, it's confusing for the individual when we sort of blur those boundaries. And it really is incumbent upon us to ensure that we keep those appropriate professional boundaries. And ultimately, it's the line that allows us to provide healthcare to an individual without being compromised. So those boundaries guide our interactions. Yeah, for some patients, you might have patients that you've had for years and years and years. And, at the end of a session, they walk up to you and they give you a hug. "It's great to see you, Dr. Hockenberry. I really appreciate that." In other interactions, when we talk about professional boundaries, nurses have to have physical contact generally with individuals that they're working with. Counselors don't. And so, our boundaries depend on our relationship and our profession and what our scope of work is with the individual. So those parameters really do help to keep us as objective as we possibly can. And so how we maintain those boundaries are setting proper limits, and being aware of an individual's thoughts or feelings, things that they say, gifts that they might bring us. Certainly those can be challenges as well. And knowing what to do with those gifts, knowing how to be able to monitor what's going on with our client and their feelings is very important. So again, set firm limits, explain why we're setting those limits without just outright rejecting the individual in such a way that they're less likely to come back. I'm just briefly going to go over self-disclosure and then open it up. So, when is it okay? So in terms of self-disclosure, what are you comfortable providing to your patients?
My name.
Your name, okay. All right. Good, good.
No, I think it depends on it depends on the client, it depends on the context. I think if you're disclosing something because you think them having that information will be helpful to them, that's different than if you're disclosing something to sort of like quell your own anxiety or something else. But if it's to the benefit of the patient.
Yeah, absolutely. Yeah, thank you for sharing. If it's to the benefit, really, that's what it comes down. Is it to the benefit of the patient? And so, what are you not comfortable disclosing? Now remember, they can Google us, right? And patients do that. I can tell you there's a lot of things I'm not comfortable disclosing. I mean, I don't want people to know when I'm going on vacation. My preference is they don't know where I live. I don't necessarily talk about my family and those sorts of things with my patients. There's a lot of things that I'm uncomfortable with, and I think I see nods of heads there. I think many of you feel the same way about that. Any comments? Okay. So just in closing, things to consider, what is your goal in providing them with this information? Are we doing it for them? What will the information mean for the client? Are there confusing messages when we share where we live, when we share certain things, about our personal life? What does that, how are they going to take that? Are they going to take that to mean that, hey, we're more friends than you're my doc? Or we're more friends than just being counselor and patient, and that does get confusing. Is what we share meeting the counselors, the client's need or the patient's need? Is there another way to accomplish the goal without personal disclosure? And I find this interesting. Are you okay with everyone in the clinic knowing the information? Are you okay with other patients, with other staff's patients, on somebody else on another caseload? Are you okay with them knowing that information? So I think I'm going to go ahead and just stop right here and open it up to any questions or comments.
Excellent. Thank you so much, Al. Yeah, so we've got a few minutes left, I think 5 or so. So yeah, feel free to unmute yourselves with the microphone icon or write in through the chat box. Yeah, Dr. Ryan.
This is Dr. Joe Ryan. My background is emergency medicine and EMS, and one of the things that you didn't comment about, which is a core principle of ethics, is that of autonomy.
Yeah.
And it seems that these kinds of relationships with patients with these problems really have a confused relationship about that patient's autonomy and their responsibility for their decisions and actions. Can you comment about that and how you navigate it?
Yeah, so when you talk about autonomy, you're talking about their autonomy in terms of their ability to make their own decisions about their own behavior. Am I?
Well, certainly, and their acceptance of the consequences of their actions.
Absolutely. I think what we saw with that case that Dr. Andraki presented earlier, that individual has to accept the consequences of their actions. It's not ultimately upon us to, in many ways we do try to influence them by providing accurate information about services that are available and what our recommendations are. But certainly they can take that, you know, using an MI approach, they can take that any way they want. I'm not sure if I understood your question, Doc.
Well, if you enter into a relationship with a patient and you establish parameters that the patient will be honest with you and there are consequences for their recidivism, what's appropriate in terms of continuing or ending that relationship with the patient?
That's quite the challenge.
Yeah, I mean, absolutely. So, I mean, because they don't follow your recommendations, the fact is that most of the patients that we work with don't do what we'd like them to do. And so I think, unfortunately, you have one shot at it. I mean, your shot might be 10 minutes, maybe 20 minutes with it, with an individual, and they're gone, right, in through the emergency department. For us that have an ability to have an ongoing relationship, we can try different tacks with them. We can try different approaches with them. And at some point in time, we might say, look, you know, I've tried everything I know, you know, and it's not working for you. Maybe I could refer you somewhere else where you might get better results.
Really? I mean,
yes, absolutely.
I mean, that seems like a good idea in theory, but you know, oftentimes these people don't have any other options.
Which is exactly why I said I'm willing to try any way that I can possibly try, and any intervention that I can try. I'm not going to kick somebody out of treatment for having a positive UA. That's not what I said. And the you know, if I see any positive steps, I'm going to reward those. I'm going to try to use contingencies. I'm going to try to use motivational interviewing. I'm going to use medications. I'm going to do everything that I possibly can to keep that person engaged in treatment, number one, because we know, as you mentioned, and your response to me was like, look, we know retention's the name of the game. The longer we can keep people engaged in treatment, the better they're going to do. But at some point in time, if we've exhausted what we have, and there are other options, I think it's important for us to explore those other options.
What's the scope of the patient's responsibility in that doctor-patient relationship?
Well, I think in any healthcare relationship, I think ultimately the responsibility is on the patient. I think ultimately they have the choice to do whatever it is that they want. They can choose not to come back and see us.
I do want to get to a comment from Aaron. Some personal disclosure may allow you to relate to the patient more, so they are more open to sharing their information, which would help build rapport.
Okay, so give me an example of that.
Aaron, I'm going to take you off mute. Could you share a little bit more?
I don't know, just thinking about in my personal experience as a nurse working with PACU patients and patients that I've had patients who don't do well with the anesthesia just because of their history with medications and drug use. And so sometimes just opening up and sharing, even if it's just a small tidbit about what kind of dog you have, sometimes they feel more connected and then are willing to tell you like when the last time they used was and stuff. So I don't know.
Okay.
Helps connect and helps them open up some.
Yeah, so you're really looking to set them at ease. You're not necessarily, I mean, I'm not sure how personal letting them know that you have a golden retriever is, as opposed to sharing other personal information about yourself. I mean, if I certainly wouldn't, I wouldn't say that isn't personal information that would be off base to share, especially if you know that person likes dogs. You know, I wouldn't see a problem with that.
Yeah. Of course, I would never share anything that would be personal that would be detrimental to my reputation or anything like that, but just sometimes connecting with them, making them realize, oh, this is a human I'm talking to, not just a nurse. I don't want to tell them anything because they're just going to judge me for it. So sometimes just talking to them, they will understand like that you have a background too. And I don't know.
Sure. And I think establishing rapport is incredibly important for everything that we do.
Mm-hmm.
And establishing rapport to get people to listen to you, establishing rapport to get them to open up and evoke and to share some of the things that they might not really want to share with anybody. I think that's crucially important.
Yeah. Thank you.
All right. We are a little over time, so I just want to wrap up for the day and say a special thank you to Al for this great presentation today. It definitely spurred some excellent discussion and some questions. So thank you for that. Thank you, Ben, for coordinating with me on this, and thanks to the Opioid Response Network and Nevada Primary Care Association for your partnership for this session today. I do want to do a quick plug of our ongoing series for medication-assisted treatment. So our next clinic will be on Wednesday, October 23rd from noon to 1:30. It's going to be the same Zoom link that you used to join us today. And we're going to be talking about outpatient detox and maintenance therapy. And then you can see the remainder of our topics for the rest of the year. So we're going to have some more guest speakers from the Opioid Response Network for this December 11th Trauma-Informed Care presentation. So we hope you'll continue to join us for these, sharing your challenging patients, sharing your thoughts and concerns surrounding MAT treatment. And then there's a quick survey that I'd like to share as well, just asking you about your satisfaction with the session today and if we met the objectives. So thanks again, everyone. Thanks, Al. Thanks, Ben. Thanks, Jennifer. Hope to see you all join us in another couple weeks. Take care.
Thank you all. Appreciate it.
Thanks.